Update on COVID-19 for physiotherapy staff. A coronavirus is a type of virus. As a group, coronaviruses are common across the world. COVID-19 is a new strain of coronavirus first identified in Wuhan City, China in December 2019. On the 11th of March 2020, COVID-19 was categorised as a pandemic. The incubation period of COVID-19 is between 2 to 14 days. And based on current evidence, the main symptoms of COVID-19 are a cough, a high temperature, and in severe cases, shortness of breath. Lack of immunity is a characteristic of this virus. COVID-19 has the potential to spread extensively. No one is immune at this stage. We are all susceptible to catching this disease. If infected with COVID-19, some will exhibit no symptoms, some mild to moderate, but self-limiting illnesses similar to the seasonal flu. However, it is evident that a minority of people who get COVID-19, approximately 20%, will develop complications severe enough to require hospital care, most often pneumonia. A small proportion of these will die. High risk, elderly people and those with underlying health risk conditions in the same way as the seasonal flu are more seriously affected. Serious complications are less common and usually less severe in younger adults. So far, there has been no obvious sign that pregnant women are more likely to be seriously affected. This is a very young virus, so it is very hard to determine what the effects are on the unborn child. Effects of COVID-19. Fever in 87.9% of patients, a dry cough in 67.7%, fatigue in 38%, sputum production, 33.4% of patients have this. Shortness of breath is in 18.6%, muscle pain or joint pain in 14.8%, sore throat in 13.9%, headache in 13.6%, chills 11.4%, nausea or vomiting in 5%, nasal congestion 4.8%, and diarrhea 3.7%. Transmission occurs from person to person through respiratory droplets that travel up to 2 metres and may enter the respiratory tract of individuals within range, or through contaminated surface leading to infection through contact transmission. For example, if you touch an infected surface and then touch your face or mouth, you can contract this coronavirus. The respiratory droplets are prevalent during aerosol generating procedures, and this, although the transmission is droplet, aerosols are emitted during these procedures, and this is when we need to take extra precautions. The virus can survive up to 72 hours on stainless steel or plastic, or 24 hours on cardboard. And other sources have suggested that it can survive 5 days on inanimate objects. So our disinfection and decontamination of any equipment that is near any of COVID-19 positive patients is vital. Aerosol generating procedures increase the risk of aerosol spread of infectious agents, and airborne precautions must be used. All secretions and excretions except sweat should be regarded as potentially infectious. The action card, where a patient with suspected or confirmed coronavirus requires acute emergency physiotherapy in the out of hours period, the following actions must be taken. We need criteria for referral, so that the patient has been seen by a consultant or senior doctor and deemed essential for chest physiotherapy. That there is evidence of retention of secretions where the patient is unable to clear independently. Decreased lung volume, compromised work of breathing, or hypoxia with at least one of the above. And the process is in hours, bleep 1349 with the details, and out of hours, contact the on-call physiotherapist via switchboard. The minimum data set should be obtained. On pickup of call, please provide the minimum data set, the name of the referrer, the patient's name, age and health and care number, the ward and area they are, the COVID-19 status and their diagnosis, date and stage of COVID disease progression, diagnosis and history of present condition including the following: level of consciousness and cooperation, temperature, cardiovascular status, recent chest x-ray, recent ABGs with SaO2, breathlessness and colour, sputum, current medical management plan, which includes their oxygen therapy and humidification, bronchodilator therapy, analgesia, fluid balance, plus minus diuretics, ceiling of care, past medical history. What equipment is available in the patient area, for example, suction, stethoscope, oxygen point, air point. Confirm that there is a body available in the given area, and inform the referrer of expected arrival time and advise on any appropriate interventions prior to that, whether it's the administration of analgesia or bronchodilators. If the patient is positive COVID-19, please ensure clear communication with the referrer that emergency on-call physiotherapy is indicated. Many patients presenting with COVID-19 will have no specific airway clearance needs. It is important that staff contact is kept to a minimum with positive patients to help reduce the risk of transmission. However, the decision to see the patient should be based on the reported clinical findings and presentation, not the infection control status, i.e. you cannot refuse to see a patient because they have COVID-19. COVID-19 patients to date who require hospitalisation are presenting with pneumonia features and bilateral patchy shadows or ground glass opacity in the lungs. There have not been reports that COVID-19 positive patients have high secretion loads requiring intensive respiratory physiotherapy or airway clearance. There may be patients with existing respiratory conditions who require personalised physiotherapy treatments, which may include mechanical airway clearance or oscillating devices. In this scenario, it is important that the risk and benefit of continuing with the regime is discussed with the consultant respiratory physicians or critical care consultants. It may be decided that airway clearance regimes are continued in this scenario, ensuring COVID-19 suspected or positive patients are managed in isolation and full PPE and decontamination advice followed. This is a table of the transmission-based precautions and the personal protective equipment for the care of the patients with the COVID-19 virus. This is our action card for physiotherapy on-call criteria, indirect or direct contact, whichever is required, and the management and modalities that we can use to offer these patients. Physiotherapy intervention for COVID-19 patients, aerosol generating procedures. If after discussion with senior medical staff it is deemed appropriate or necessary to use an airway generating procedure, full PPE must be worn, including an FFP3 mask. The aerosol generating procedures potentially used by physiotherapists include manual insufflation, exsufflation, such as the cough assist Emerson or Clearway, manual techniques such as percussion, vibes or assisted cough, sputum induction, any mobilisation or therapy that may result in coughing and expectoration of mucus, PEP, a cappella, the vest, aerobica or mobilising the patient. open suction, intermittent positive pressure breathing, alpha, treating patients on Airvo or NIV, and manual hyperinflation. For patients with suspected or confirmed COVID-19, any of these potentially infectious AGPs should only be carried out when essential. Where possible, these procedures should be carried out in a single room with the doors shut. Only those healthcare staff who need to undertake the procedure should be present. A disposable, fluid-repellent surgical gown, gloves, eye protection and an FFP3 respirator should be worn by those undertaking the procedure and those in the room. The room should be decontaminated 20 minutes after the procedure if it is in a negative pressure room, and if it's in a side room it should be 1 hour. The patient should be guided to cough into a tissue and dispose of immediately. Aerosols generated by medical procedures are one route for the transmission of the COVID-19 virus. The following procedures are considered to be potentially infectious AGPs: intubation, extubation and related procedures, tracheostomy and tracheostomy procedures, manual ventilation, open suctioning, bronchoscopy, non-invasive ventilation, e.g. bi-level positive airway pressure or continuous positive airway pressure ventilation, and also high-flow nasal oxygen. There is a query at the level of 6 litres per minute. Whenever high-flow nasal oxygen is administered at a flow rate of greater than 6 litres, it has the potential to become more of an aerosol generating procedure. Continuous airway generating procedures such as NIV and Airvo may pose additional risk. There also appears to be evidence that moving to early intubation is preferable, and the benefits of delay with NIV are unclear. Therefore, consultant intensivist guidance is advised and necessary. There is the fear that patients who are deteriorating may be masked with the use of NIV and Airvo. Patients treated with either high-flow nasal oxygen or NIV should be monitored closely for deterioration. Know if the patient is for escalation and don't delay. High-flow nasal oxygen over 6 litres per minute and NIV should be used only in selected patients with hypoxemic respiratory failure. Initiate oxygen therapy at 5 litres per minute and titrate flow rates to reach greater than 93% during resuscitation, or use a face mask with a reservoir bag at 10 to 15 litres per minute if patient is in a critical condition. Once patient is stable, the target is greater than 90% in non-pregnant patients. Patients may continue to have increased work of breathing or hypoxemia when oxygen is delivered via a face mask with reservoir bag. Hypoxemic respiratory failure in ARDS commonly results in intrapulmonary pressure, ventilation perfusion, mismatch or shunt, and usually requires mechanical ventilation. No humidified oxygen should be given. Nebulizers. Certain other procedures or equipment may generate an aerosol from material other than patient secretions, but are not considered to represent a significant infectious risk. Procedures in this category include administration of pressurized humidified oxygen and administration of medication via nebulization. NB, physio staff to wear an FFP3 mask for all chest physiotherapy. Sputum samples and request forms should be marked with a biohazard label. Specimens should be double bagged. The specimen should be placed in the first bag in the isolation room by staff member wearing appropriate PPE, and tube systems should not be used to transport specimens. They should be transported by porter staff. If the patient is requiring nasopharyngeal or oropharyngeal suction and is awaiting intubation, do not proceed. If no plan to intubate, perform suction with double glove technique, ensuring long sleeve gloves remain in situ until doffing. Staff should not re-enter the room for 1 hour if possible, and the room decontaminated afterwards following this aerosol generating procedure, and keep the door closed. Moving on to the ICU environment, this is a slide on the ventilator settings from the typical ventilators that are in intensive care unit. So on the screen there is the mode of ventilation, the oxygen level at the side, the patient's PEEP, their set respiratory rate, set tidal volume. This is the button where the 100% O2 breaths can be given. These will give 100% oxygen to the patient for 2 minutes. This value here is the patient's actual tidal volume inspired and expired, so it correlates closely with the set TV. This is the actual respiratory rate, so as this is number 10 and this is 16, the patient is taking 6 breaths for themselves. The peak inspiratory pressure is the pressure that the patient is receiving as a maximal. The types of ventilation. Controlled modes are where every breath delivered to the patient is a mechanical breath, for example PRVC, pressure regulated volume control. Supported or spontaneous mode is where every breath is spontaneous and triggered by the patient but is supported by the ventilator, for example pressure support with CPAP. A combination mode is a combination of controlled and supported, for example auto mode. We do not, as physiotherapists, alter the ventilator settings. We leave those. But do familiarise yourself with where the oxygen breaths button is in case of a patient's sudden desaturation. So the pressure regulated volume control is a mode of ventilation in which the ventilator attempts to achieve a set tidal volume at the lowest possible airway pressure. Auto mode helps patients transition into spontaneous breathing. It is an interactive mode that switches between controlled and supported ventilation conditional to patient effort. So it will allow the patient to be supported in their breathing, but if they have a prolonged period of apnea, it will switch over into pressure regulated volume control. CPAP with pressure support provides continuous positive airway pressure with additional support during inspiration provided by pressure support. And some values to know: PEEP is the positive end expiratory pressure, which maintains the end expiratory pressure to help prevent alveolar collapse and improve oxygenation. Peak inspiratory pressure reflects airway resistance and lung compliance. It is elevated with increased resistance or decreased compliance. The tidal volume is the amount of air either inspired or expired by the patient, and the minute volume is the volume of gas the ventilator will deliver to the patient in 1 minute and is measured in litres. The minute volume is the respiratory rate multiplied by the tidal volume, and this value can go down after suctioning and cause the ventilator to alarm. Reports from centres with ventilated COVID-19 patients at present are that chests are dry and minimal secretions are present. But we must keep in mind underlying respiratory conditions and that there is always the potential to develop secretion retention due to ventilation or prolonged paralysis, probably around day 5 of intubation. So, hyperinflation in ICU. Patients in ICU should not be disconnected from the ventilator for manual hyperinflation without specific discussion from the consultant intensivist. Disconnecting a patient from the ventilator results in a loss of PEEP and atelectasis. A specialised procedure for switching off the ventilator before and after attaching bagot circuit and the tube clamping must be carried out by medical staff to limit the contamination of the environment. This is different from the normal process for bagging where an artificial lung is attached to the ventilator. The consultant may choose to carry out recruitment manoeuvres using the ventilator instead of manual hyperinflation. But manual hyperinflation and ventilator hyperinflation are unlikely to benefit patients with a COVID-19 due to severe inflammatory picture. Patients potentially could be ventilated outside of ICU. This is not the case at present. Patients may be ventilated in main theatres and in recovery. Further contingency plans may follow if there is demand for more ventilated bed spaces. Main theatres have no ACUTE, therefore use normal paper notes. Cards with ICU assessments are available in the duty room drawer, and this may change in the coming weeks. You may need to go to the theatre reception opposite the end of the canteen corridor below haematology and orthopaedic ward to get a fob to access theatres. And you may be required to help with other tasks that you would not normally do within your scope of practice when you're treating these patients. For example, helping with repositioning. This is just a sheet of the ICU physiotherapy assessment and the OBS that we would have generally taken and written down manually. ARDS is what the patients appear to be experiencing whenever they have reached critical care in ICU. This is a complex syndrome and its complete etiology isn't fully understood. However, ARDS usually starts with a massive insult to the lungs. In the lungs, inflammatory mediators such as interleukins can damage the alveolar epithelial and endothelial capillary membrane and degrade the plasma basement membrane. Damage to these tissues lets protein-rich plasma leak into the alveolar space, leading to pulmonary oedema. As this fluid further damages the alveoli, surfactant production is decreased, leading to atelectasis and hypoxemia. Therefore, ARDS is characterised by a combination of atelectasis, decreased surfactant, protein-rich pulmonary oedema, and interstitial inflammation, especially in the dependent areas. A hallmark of ARDS is that the pulmonary oedema isn't cardiac in nature, and many young patients with ARDS do not have a significant cardiac history. Pulmonary oedema causes the lungs to eventually become stiff and non-compliant, making optimal ventilation even harder to achieve. The fluid in the alveoli causes another hallmark characteristic of ARDS, the inability to improve arterial oxygenation with an increase of delivered FiO2. The medical management of ARDS involves identifying and treating the underlying cause, using low tidal volumes to reduce barotrauma, as mechanical ventilation can overexpand aerated alveoli. These overexpanded alveoli lose their elastic recoil, compress adjacent blood vessels, reduce blood flow and trap air, preventing oxygen from entering the circulation. Limiting PEEP as much as possible because high levels of positive pressure can cause barotrauma, damaging alveolar capillary membranes. High PEEP can also lead to alveolar rupture and then cause increased permeability of the alveolar walls, leading to a further increase in pulmonary oedema. So allowing permissive hypercapnia, they use low tidal volume ventilation, which raises the patient's PaCO2 level and may result in hypercapnia. But letting the hypercapnia and respiratory acidosis develop gradually in patients with ARDS can limit ventilator-induced lung injury, and studies have shown that patients can tolerate moderate permissive hypercapnia for long periods of time. And the other management approach is using the prone positioning. In adult patients with severe ARDS, prone ventilation for 12 to 16 hours per day is recommended by the World Health Organization. The application of prone ventilation is strongly recommended for adult patients and may be considered for paediatric patients with severe ARDS, but requires sufficient human resources and expertise to be performed safely. An excellent YouTube video is Proning the ARDS patient and why we do it. It gives a good explanation as to why we put the patient in prone, explaining how the fluid that gathers in the dependent areas of the lungs will move to the anterior of the patient's lungs, which are smaller instead of the dependent posterior and bases of the lungs. So in the prone position, the fluid will all gather at the front, but at the back of the lungs and at the bases we have more room for gaseous exchange. So the prone position improves ventilation perfusion mismatch, improves oxygenation, keeps the alveolar units open and evenly distributed at the end of expiration, and allows recruitment of these dependent lung regions. The decontamination of equipment. As said before, this is paramount to prevent transmission of this infection. Reusable, non-invasive equipment must be decontaminated between each patient and after patient use, after blood and body fluid contamination, and at regular intervals as part of equipment cleaning. An increased frequency of decontamination should be considered for reusable non-invasive care equipment when used in isolation or cohort areas. Reusable equipment should be avoided if possible. If used, it should be decontaminated according to the manufacturer's instructions before removal from the room. If it is not possible to leave the equipment inside the room, then follow infection IPC guidelines on decontamination. This usually involves cleaning with a neutral detergent, then a chlorine-based disinfectant such as Actichlor in the form of a solution at a minimum strength of 1000 ppm available chlorine. If possible, use dedicated equipment in the isolation room. Avoid storing any additional equipment in the patient's room. Dispose of single-use equipment as per clinical waste policy inside the room. Ventilators and mechanical devices, e.g. your cough assist machines, should be protected with a high efficiency viral bacterial filter such as this one. When using mechanical airway clearance, filters should be placed at the machine end and the mask end before any expiratory or exhalation ports. Filters should be changed when visibly soiled or, depending on the filter, used either after each use or after 24 hours, and complete circuit changes should be undertaken every 72 hours. Closed system suctions should be used if patients are intubated or have tracheostomies. And any additional items such as stethoscopes, pulse oximeters, ultrasound probes taken into the room will also need to be disinfected, regardless of whether there has been direct contact with the patient or not. And this is due to the risk of environmental contamination of the equipment within the isolation room. For mobility assessment and rehabilitation of patients who have been confirmed with COVID-19, only see the patient directly if indicated. So if patient is not at their baseline level of mobility or to improve their respiratory function. PPE as recommended, donning and doffing. There should be a buddy present and assessment of mobility carried out as usual. Try to limit the number of assessments as able. For example, use joint assessments with OT for patients who are requiring assistance of two, and treatment options decided and communicated to buddy if equipment is needed, for example, delta relators or wheel Zimmer frames. Give advice on equipment if able, and provide advice towards staff and document in the nursing notes. Rehabilitation can be provided if essential to facilitate discharge and improve respiratory function. This may be delivered by physio assistants and/or physios. Agree discharge pathway with MDT as for any other patient, and discharge home and refer on as appropriate, but be aware to limit the number of referrals if able. Ensure onward referral destinations are aware of the patient's COVID-19 status. Allocated staff will manage COVID-19 patients on a rotational basis to minimise cross-working between COVID and non-COVID patients. Initially, COVID-19 patients' assessments and treatments to be kept to the end of the shift. And staff should not wear a uniform outside of the hospital. Uniforms should be transported home after each shift in a disposable plastic bag and dispose of this bag in household waste stream. Launder uniforms separately and from other household linen in a load not more than half the machine capacity at the maximum temperature that the fabric can tolerate, then ironed or tumble dried. There is talk about scrubs being used, but they are not in stock at this present time. In summary, chest physiotherapy must be clinically indicated. Clear rationale if using airway generating procedures. FFP3 masks and personal protective equipment should be worn for all chest physiotherapy. The chain of command, the phone numbers of senior acute inpatient staff, is available if anybody wants to discuss their management of a patient with or without COVID-19. There's the WhatsApp group for ensuring there is adequate cover at short notice and for staff and peer support. Please do not put any patient details on this WhatsApp group. And we have endeavoured to give the most recent recommendations based on the current and emerging evidence, but this is changing daily, so please keep up to date. So these are unprecedented times for all healthcare staff. We are here to support you and appreciate the efforts being made by the physiotherapy team to prepare for the predicted demands on our service, and teamwork will be what gets us through this. Thank you for listening.